This presentation provides an overview of heparin drips. We will walk through how to follow an example of a heparin drip protocol, as well as some of the general considerations for continuous heparin infusions. When we discuss heparin drips, it's really important to start with the why. Why would someone need a continuous infusion of heparin, of an anticoagulant? Well, DVTs and pulmonary emboli are some of the most common reasons for this. Remember, venous clots. Now, giving IV heparin is very different than giving subcutaneous heparin. If you recall, heparin is a very variable drug. Our free drug levels will vary from patient to patient, and it can be really difficult to predict. So heparin is a drug that is titrated when given IV. Therefore, anytime we titrate a drug, remember fentanyl or pancuronium or midazolam, all of those IV drips that are titrated by the nurse, we must follow a protocol. Otherwise, we're prescribing and practicing outside of our scope of practice. So here you can see one of those protocols. This protocol is attached in your weekly module if you'd like to review it up close during this part of the presentation. And these protocols will vary by hospital, so you don't need to memorize them per se, but we're going to look at this specific protocol, and most of them will look somewhat similar and follow very similar principles. So let's take a look at this protocol and see how we would start a heparin drip. So if you take a moment to glance at this protocol, you'll see a lot of kgs or kilograms. This protocol is based off of our patient's weight. So you can see how important it is to get an accurate weight on your patient before moving forward. So imagine the ripple effects of using an inaccurate weight from the beginning. So once we have that accurate weight, you can see that the first thing we need to do is assess our patient's baseline labs. So why are we doing this? Well, back to what we said about anticoagulants and antiplatelet drugs, we're worried about bleeding and the potential that our patient could bleed. So we need to see if our patient is already at risk for bleeding, if they're anemic, if they have low platelets, maybe their PTT is already really high. You'll note that the protocol says to discontinue all other heparins. And we want to control as much as we can with this protocol. So any subcutaneous Lovenox or heparin, for example, should be stopped. Now, because we don't want to just slowly start this drip of heparin, we need to kind of jumpstart it or load up our patients with heparin before we kind of settle down into a maintenance rate. And this is why we start with an initial bolus. So you can see there is a calculation for how much of a bolus we give based on our patient's weight again. So note that because we are using a high-risk drug, an anticoagulant, this should be programmed into the IV pump using what are called guardrails often. And basically, we're telling the pump that we're giving a risky drug. And the pump has preset warnings built in so that if we accidentally give way too high of a dose of heparin, it's going to warn us and basically say, that seems like a very high dose for heparin. Are you sure you want to do that? So we program the pump to administer this quick bolus of heparin to get our patients started. And then next, you see we're going to start our infusion rate. So do you see the difference here? Our bolus was 80 units per kilogram, and the maintenance drip rate is only 18 units per kilogram. So it sounds more like maintenance, right? So when you do these calculations, you should note that your infusion rate should be much lower than your bolus rate. And this can be really a helpful way to check your math. So moving down this protocol, we've delivered our bolus, and now we've got our infusion running. Next, it tells us that we need to check an APTT every 6 hours. So remember that an APTT should be a little longer, 1.5 to 2 times longer than a normal APTT, since our patient is getting heparin and they have maybe a venous thrombus that we don't want to clot as quickly. So we go into our patient's room and we draw the blood and we put it in the tube and we send it down to the lab. And we'll be checking the EHR and trying to see if our results are up. Sometimes we'll even call down to the lab to see if they have our results. But we wait a little bit to see what our patient's APTT is. Once we get the results, we need to take a look back at our protocol. What do we do according to the results that we've got? So you can see here, we need to see where our APTT falls. Is it below 30, between 30 and 51, between 52 and 67? Notice that area is shaded, and that's exactly where we want our APTT to be. That's the sweet spot. Is it too high, like 68 to 95, or is it even above 95? So notice that if our APTT is too low, we end up giving more heparin, giving another little bolus or increasing our rate. That makes sense, right? So we want our heparin to increase our APTT. So if it's too low, we need more heparin. If our APTT is too high, our heparin is working a little too well. So we end up turning down our rate or even pausing the infusion for an hour. So we continue this process of checking APTT, making changes to the rate as necessary, and then checking APTT in 6 more hours. But notice if we hit that sweet spot twice in a row, that shaded area of 52 to 67, then it's not necessary to monitor our patient as closely. So we can move to checking the APTT only once every 24 hours. But that's only if we hit that shaded area of 52 to 67 twice in a row, so every 6 hours for 2 times. So let's test your knowledge. Get a calculator, your heparin drip protocol that you have in the module, or you can use the one on the screen here, and some paper, and let's work through a heparin drip order from the beginning. So here we have Mario. And Mario was just diagnosed with a saddle pulmonary embolism, and this basically means a pulmonary embolism that is straddling the main pulmonary arterial trunk. So you see Mario weighs 176 pounds. Now remember, you first need to check the patient's baseline labs, you make sure that he has good IV access, you grab tubing, you get the bag of heparin, and you can see the bag label here to the right. You verify your orders and that you have the correct medication with another nurse. And you make sure that the concentration in the heparin bag is correct and consistent with the orders in the EHR as well. So you pull up the protocol and you need to begin with an initial bolus. Pause the presentation and calculate how much the initial bolus should be. You'll first get a number in units, and then using the heparin bag label on the right, calculate how many milliliters that bolus will be. Pause the presentation and calculate your answer. So the first thing to remember is that these calculations are for kilograms. So we need to start by converting pounds to kilograms. There are 2.2 pounds in every 1 kilogram. So remember, someone will always have a higher number in pounds than in kilograms. So 176 divided by 2.2 is 80. So this patient weighs 80 kilograms, and we will use this for the rest of our calculations. Then you can see here that the bolus is 80 units per kilogram. So 80 units for each of those 80 kilos, which would be 80 times 80, or 6,400 units. So this patient, Mario, will be getting a loading bolus dose of 6,400 units. And notice our max bolus dose is 8,000 units. So this kind of helps me recognize that the math is probably in the right ballpark. I didn't get 64,000 units or 640 units. I'm closer to the max, but I'm not over the max. So we've got this 6,400 units, but next you need to verify that this bolus dose is correct with another nurse. Have them check your math. And now you need to actually administer that bolus. Well, our heparin is available to us in a mixed bag of 5% dextrose. So we aren't just giving straight units of heparin. We need to see what the concentration is. So here we see that every milliliter of fluid in this bag will have 100 units of heparin. So that tells me that there is a lot more heparin than milliliters in this bag. We have 100 units in every milliliter. So it's pretty concentrated. So I'm going to anticipate having to give less fluid than the number of units. So less than 6,400 milliliters. That would be 1 unit per milliliter. So to figure out how many milliliters to give Mario, I take 6,400 units and divide that by 100. So basically I'm asking how many 100 units are there in 6,400 units. So the answer is 64. So this patient will get 64 milliliters of this solution from this bag. Now, note that some hospital protocols indicate that you actually administer this heparin bolus via IV push, because if you think about it, 64 milliliters is still a pretty significant amount of fluid. So they would use a higher concentration of heparin to deliver that quick bolus, but that's going to depend on the hospital and on the protocol. So now our bolus has been administered. What's next? So looking at number 5 on this heparin protocol, we need to calculate the infusion rate. Pause the presentation and calculate the starting infusion rate for this heparin drip. How many units, and then how many milliliters per hour will the pump deliver? So we still have our 80 kilogram patient, but he's going to be getting 18 units per kilogram each hour. So we take 80 kilograms and multiply this by 18 units, which is 1,440 units. Notice this is below the max dose of 1,800 units per hour, which again helps us verify that our math is on the right track. So 1,440 is the number of units Mario will get each hour, but how many milliliters of this IV bag of fluid will he get? So with 100 units in 1 milliliter, we take that 1,440 units and divide it by 100, which is 14.4 milliliters per hour. So now before actually typing that into our pump, you would verify this rate change and check your math with another nurse. So what's next? Well, per the protocol, we need to draw an APTT every 6 hours. So you would send this down to the lab and wait for your result. You see that Mario's APTT is 28. So what do you do next? Take a look at the protocol and pause the presentation as you calculate what adjustments might need to be made in milliliters and milliliters per hour. You can see here that his APTT falls into this category. It's below 30. So think about this. He didn't get enough heparin. It's not in that shaded spot of 52 to 67 yet. So we can anticipate that he's going to be needing more heparin. And in this particular protocol, it's asking us to re-bolus him with 60 units per kilogram and then follow that by restarting his continuous drip rate at a faster rate, so 2 more units per hour than we were running it before. So let's calculate the bolus first. We have an 80 kilogram patient and our bolus is supposed to be 60 units per kilogram. So 80 multiplied by 60 is 4,800 units. Therefore, if we use this bag of heparin to deliver that bolus, we divide that 4,800 units by 100 units per milliliter and get a 48 milliliter bolus. So now that we've checked our math with another nurse and administered the bolus, we need to see what our maintenance rate will be. So our protocol says to increase the rate by 2 units per kilogram per hour. So since our starting rate was 18 units per kilogram per hour, we now increase that 18 to 20 units per kilo per hour, a 2 unit per kilo per hour increase. So we multiply 20 units by 80 kilograms and we get 1,600 units per hour. And again, we divide this number by 100 to take into consideration the concentration of heparin in the bag, and we get 1,600 divided by 100, which is 16 milliliters an hour. So now we're set for 6 hours. We are going to be running at 16 milliliters an hour, but 6 hours after we make this change, we need to go into Mario's room and draw a PTT. So you can see how these patients not only require a lot of monitoring for signs of bleeding and complications from heparin, but we are drawing these labs, waiting to get these lab results, and calculating very important adjustments to their heparin drip rate throughout the shift.